Is that, so that's going to be streaming to the Facebook page?
YouTube.
YouTube, sorry. And then do we post the link to
their Facebook page?
Okay.
Or I'll send you the link and then YouTube.
YouTube, sorry. And then cool. We post the link to
their Facebook page.
Okay.
Okay, hold on.
YouTube, sorry. And then cool. We post the link to you.
It's all good. Happy to help. It's almost there. As soon as it's up,
it will pretty much start. I guess I'll just wait a minute.
And we're live now.
Okay. Cool. Oh, I just can't see it on the page. Mu-Ming, is it up on the page?
Cool. Yeah. So I've just sent you the link and I'll post it on the Facebook page now as well. And then we're good to go.
Oh, okay. Sweet. And so can I watch it through that link? Is that the best way to do it? Or, okay. I guess I can watch it through Facebook too.
There we go.
Okay. Sweet. Should I just go as normal through my Zoom, or should I just comment? Should I open that and look at that one as well, or is it easier if I just kind of use Zoom?
Just use Zoom, probably.
Okay.
Because it's sharing your screen, and then I'll keep tabs on it from my end.
Thank you. Okay, amazing. Well, I'll and can you see how many people have tuned in?
Yeah.
On your side? Okay. Do you mind letting me know when there's a couple?
Yeah.
Sweet.
Cool, will do.
And then I'll get started when there's a few. Okay. I'll get the slideshow, play from the start. All right, cool. For anyone tuning in, if you could just comment on the Facebook and let me know if that you can hear that and that's working for you. We'll get started soon. Just obviously there's been a bit of a few problems technology-wise, and Mu-Ming has saved me here. Okay. Mu-Ming, is there anyone that's tuned in yet? All right, for anyone coming in, oh, just check this. Okay. Sweet. All right. So I'm going to wait a few more minutes to start because obviously there's been a bit of a change of time thanks to my incompetency with technology. But really sorry that it wasn't at 11. My Wi-Fi's been a bit all over the place, so it really wasn't really working. So luckily Mu-Ming's come and saved me here. So we're just having to run through Zoom. But I'll get going in about a minute or so, and then this will be recorded so anyone can come back and watch it later too. All right, thanks, Tommy. Okay. All right, cool. Well, I might just get started, and then everyone is welcome to obviously watch this at a later time as well. Okay. Cool. Zoom share. Okay, checking that's working. Okay, cool. All right, so hello everyone, my name's Maxine, and I am a 5th year student. Oh, just checking that's working. Okay, cool. And so today I'm just going to talk to you about some Gen Med presentations. Obviously, it's a super broad topic. I mean, it was pretty hard to decide what to cover here. So what I'm just going to focus on is some that I felt that weren't covered super well for 4th year for me, but are super common presentations, so really important to get your head around. I've left out things such as abdominal pain and chest pain and all that, those kind of ones, because I know they've been covered by Stephen and myself in previous tutorials. So if you want any more information on that, go look at them. Definitely things like shortness of breath and chest pain, abdominal pain is super common. All right, just checking that it's gonna let me flick between these slides. I think it will. Okay, cool. All right, so just in general, I think the main thing I hope you can get away from this is a way to tackle any problem or presenting complaint that you come across. So in gen medicine, you're going to come across a whole range of different presenting complaints that might be really simple or complex, and you've got to make sure you have a really nice systematic way of going through whatever presentation comes to you. And this is really helpful if you start working through this with every case you get. It's really helpful for your future years and your OSCEs and exams and so on. So always start with your doctor's ABCs, which have been drilled into you. If there's anyone that's acutely unwell, or you're worried about each stable and the airways aren't compromised, they can breathe okay and their circulation's okay. And some of the cases and emergencies we'll talk through today that's particularly important. If given that's okay, then you want to shoot into your history and examination and investigations and management plan. As you've heard before, the one thing I'll just add to that is that I think it's always important to be thinking about, okay, what are my red flags that I'm looking out for here? And what are the worst case scenarios for each case? So one of the ones we're going to go through today is headaches. So for example, the worst case scenario, one of them would be subarachnoid hemorrhage. You want to make sure that you're doing everything in your history and investigation to rule that first. So I hope that makes sense. Right. So just to start with, we're going to talk through headaches. So as I'm sure you know, a headache is any pain that's in your head, but it also includes pain behind your eyes, your ears, or in the upper part of your neck as well. And they're very common and represent about 2% of all ED visits. And the way I've separated them in my head is into primary and secondary headaches. So you've got your primary ones, things like your tension, your cluster, your migraines, and then you've got your secondary headaches. So they're kind of things that are happening because of another problem. So maybe your sinuses are really inflamed and therefore that's causing you a headache. So, and also things like medication and caffeine can cause these secondary headaches. Cool. When you're looking at your history, firstly, you want to do all your general stuff, but some really important ones, questions to ask. So you want to know, where is the pain located? Is it bilateral or unilateral pain? So one side of the head, or is it all round? How long has the headache been there for? And is it a really sudden onset? Because that can raise some red flags. How frequent are they coming? Is it a one-off severe event, or is it more something that's been recurring? And also any associated symptoms can give you a good clue, which we'll talk through soon. Also the severity. So is it so severe they can't manage, or is it just something that's kind of a bit of a bother in the background? That can give you some clues as well. Also important to get an accurate medication history. So we'll talk about a type of headache, called a medication overuse headache. And in this type of headache, pretty much, people might not even realize, but they're using simple drugs such as paracetamol too frequently, and that can actually cause headaches as well. And also their social history is quite important in terms of emotional stress. Cool. Sorry, not a very pretty slide, but just going to run through 4 really key headaches that you should have your head around. Important to know how to differentiate between these ones in terms of a history, and because they can often come up in things like progress tests and exams as well. Cool. So first one here is a tension headache, which I'm sure you've all heard of. So often this is described as this kind of band around the head, and it's kind of like more of a tight compressing pain. I'm sure plenty of you have had it before. So it's often quite a constricting pain, and while it can be, really bothersome to their day-to-day life, it's not super severe. So it's not really, often people can go about their day-to-day with it, although it is a pain. And it's often bilateral, so it's both sides of the head. It's the steady aching, and it's non-pulsatile. So those are some key features in your history. Other thing is social history is super important for tension headache, because it's often associated with emotional stress, psychological things. So really important to do that. All right. Slides are changing. Okay, apparently my screen share seems frozen, so I'll just try to sort that out for you. How about, I'll try again. Okay, I think it hopefully is working now. Okay. Okay, sorry if you missed those slides there. Pretty much I spoke through them all, so that's fine anyway. And this will be recorded, and I'll put the slides up too. Okay. So talked about tension. So next would be cluster headache. And I mean, it's in the name, kind of the nature of this. So they often appear in clusters. So they're kind of these recurrent attacks of these headaches. They're often quite severe, and they're often unilateral and surround that kind of orbital areas. So around the eye, so they could be above, behind, or below. And they usually last, these kind of headaches or pains last about 15 to 180 minutes. You'll often see other associated symptoms, so reddened eyes, congestion, lots of tears coming out of their eyes as well, which is a bit of a clue. But yeah, the main thing is they do occur in clusters that last over weeks for months, and then there's often a period of remission afterwards. Cool. Okay. The other headache that I mentioned briefly before is a medication overuse headache, and I put the definition just there. But usually it is due to the overuse of kind of often headache medication or pain medication. So, things like paracetamol and ibuprofen that are really easy to get over the counter. People can quite easily get into the habit of taking them frequently, especially if they already had a little headache disorder before. And this can either, this overuse of drugs, I think it has to be for over 12 or so days a month, but it can lead to either a new headache, or it can worsen one that they already had. So that's why it's really important to be considering that. These kind of headaches can be harder to treat because you've got the whole withdrawal of drugs as well. So important to get onto that. And then importantly, migraines. So migraines are typically unilateral. So always a good clue in a progress test when it's telling you if it's one side or both sides. And they're typically this pulsing or throbbing pain. And as I'm sure you know, they often have this aura associated with it. And I've listed some of the symptoms there, you know, the nausea, vomiting, sensitivity to light and sound. But this aura normally only lasts less than an hour. So yeah, there's plenty of differentiating factors you can use there. And then there's also emergencies. So like I said at the start, it's really important that with every patient that's coming into an emergency department or gen med ward, you're always thinking about the worst case scenario first and ruling them out. So there's a few in the case of headaches. So one in particular is a subarachnoid hemorrhage. I'm sure you've heard this been referred to as a thunderclap headache before, and I mean typically it is in a textbook, but it's really the sudden onset, really severe persistent headache. So those are kind of, you're getting red flags in your head if it's super severe and it's come on really suddenly. And yeah, usually it's women kind of middle age 40 to 60. And I think just something I found interesting is that only about 50% actually lose consciousness. So it's important to keep in your mind that maybe they might be alert, but it doesn't mean you can rule that out. And there's you often get some abnormal neurological things, such as an abnormal fundoscopy. Sometimes your mental state can be decreased, some reactive hypertension and a fever as well. And you can get that neck stiffness with passive flexion as well. Important investigations for this, you want to get a CT without contrast. And as I'm sure you've seen, that kind of spider-like appearance, you can Google it within the circle of Willis. And you want to get a lumbar puncture, which is helpful for the diagnosis of this. And what you're looking for is the xanthochromia. So it's that yellow or that breakdown of the red blood cells, or grossly stained cerebrospinal fluid as well. And management, so there's lots of things. You want to find the cause is the key thing here. There's lots of causes of a subarachnoid hemorrhage. And so it's important that while you're trying to get the patient stable, prevent any rebleeds, you're also looking for that cause and treating it. Just two more emergencies to be aware of. So giant cell arteritis, I'm not sure if you've heard of it before, but it's this headache that you should be concerned about pretty much in anyone that's over 50 and anyone with a temporal headache or temporal pain, and especially if they have eye symptoms as well, so blurred vision or loss of vision. And it's a type of vasculitis, and it commonly does occur in your temporal arteries. And yes, like I said, very rare below 50, so don't even consider it then. They may have this kind of autoimmune history, such as this polymyalgia rheumatica, but often the presentation is the temporal headache. You can have some vision loss or blurred vision, or sometimes flu-like or jaw pain. And it's often this kind of unilateral side, but it's an emergency because if you're not onto it and you're not treating it with your steroids and getting that inflammation down, it can lead to blindness. All right. Meningitis. So always thinking about meningitis. I think you get that classic triad in 2/3 of patients where there's a fever, headache, and a stiff neck. But that's only in 2/3. So there's a third of patients that aren't actually presenting with that triad. So good to be aware of, especially being aware of this if you've got someone that's immunocompromised, has HIV, is at a higher risk. And there's lots of other symptoms that can come alongside it. So you can get this rash, this nausea and vomiting and so on. Always being aware as well if it becomes septic. So looking for like keeping their vitals, they're hypertensive, is their mental state going down, or do you have this kind of worrisome rash? So important to be aware of. And I've just listed there what you would expect to see on the lumbar puncture if it was bacterial versus viral as well. So if it's bacterial, the bacteria eating up all the glucose, and so you get a low glucose and a high protein, whereas viral, you're going to have a normal glucose and protein because they're not eating that up. Okay, cool. So on to dizziness now. And if you have any questions, if you just want to post on the Facebook page, that's probably easiest, or just message me after maybe. So on to dizziness. I think this is a super important topic to get your head around. It was probably one of the most common things I came across in my GMed. And so having a really good understanding is really important. And dizziness is a really non-specific term. So you'll see that patients use it to refer to lots of different things. So in terms of taking a history and exam, it's really important that you you really know what you're asking about and can really work out what the patient is actually trying to tell you. So they might use it to refer to something like lightheadedness, or they might use it to describe vertigo, so when the room's spinning, or just imbalance or syncope. Now, I discussed kind of syncope and cardiovascular causes in my cardio talk the other week. That's probably most important to go through some vertigo stuff today. I know that the I am reasoning talk last week as well went into a lot of good detail about nystagmus and things, so I won't go into too much about that, but I thought I'd just differentiate between the key clinical ones, conditions, which would have been really helpful, I think, for me. So just quickly, in terms of history and exam and investigation, I've listed some stuff there. Obviously, there's lots more that I've missed, but some things that I think are really important. So first and foremost, when they're saying they're feeling dizzy or lightheaded, is the room spinning? So is it this vertigo? Is it rotating around them? Or are they just feeling lightheaded and dizzy? Because there's a big difference between your differentials between the two. If it's vertigo, we're thinking potentially a vestibular or balance kind of organ problem. Really important to know if it's this one-off event or if it's recurrent, and we'll talk about why soon, and the nature of it and how long was it. So was it a few seconds, or was it over a day? Was it a few hours? Really important. And was there any other hearing symptoms? So do they have any hearing loss, any pressure in the ear, or tinnitus? So really important too. And two other things that are really good to ask, and I wish I knew last year, because I think it would have would make you stand out. So if you do think they have vertigo, two really cool questions to ask. So one is, does it feel better with your eyes open or closed? Because if it's more of a peripheral cause of vertigo, like we'll talk through, often it feels better with their eyes closed. So they close their eyes, they're getting less information, less confusion, and they feel less sick and dizzy. Whereas if it's a central cause, often it feels better when their eyes are open and they're getting more information in. Another good question would be, does it improve with visual fixation? So if you're staring at something, does that improve the vertigo? With a central cause, it often doesn't improve with fixation, whereas vice versa for a peripheral. So just some clever questions you could ask there. In terms of examination, you want to examine the ear. You could potentially also look to do some actual proper testing, audiometry, to see if there is any hearing loss. You want to do a neurological exam, including a cranial nerve exam. And then there's also specific tests and maneuvers that I'll briefly mention that are really useful for vestibular stuff. Okay. Cool. Sorry, my pictures kind of got off here, so it was a bit of a fail. But I just briefly, so the vestibular system, as I'm sure most of you know, it sits in your inner ear, next, as you can see, next to your cochlea there. And there's kind of two main, like together, you've got lateral, posterior, and anterior. And these are really important for detecting angular rotation. So like when I'm turning my head and I'm moving across these axes, those are the things that are helping me work out which way I'm turning. Whereas you've got your utricle and saccule, which you can see there, and they're more important for your linear acceleration, or determining where you are in terms of gravity. And what's important to know is that inside the utricle and saccule, there's it's really clever. There's a lot of crystals that have weight, and because they have weight, they're sensitive to gravity, and therefore we can determine where we are in space as we move with gravity. But why these are important as well is because these little crystals can sometimes break off. And when these crystals break off, they can break off into our semicircular canals and cause a lot of confusion. And that's what BPPV is. So benign paroxysmal, I can't even remember the rest of the word, but positional vertigo, that's it. So BPPV is when you're getting those crystals breaking off and it's in your canals and it's causing this confusion. And so as you can imagine, with that, every time you're kind of moving your head, that little crystal is moving around and causing this unpleasant sensation. So for that reason, a very typical history for BPPV would be someone moving their head and then feeling really dizzy. So really typical is when someone's moving over in bed, they will get this, and it's often a really short episode of vertigo, so only a few seconds, or if they're looking up at something or looking down. So they're quite key parts of a history that tell you it might be BPPV. Super common. I saw so many last year in Gen Med, and it's definitely the most common cause of vertigo. And like I mentioned, they often have lots of recurrent episodes of really short duration. So there's no associated hearing loss with this. And the diagnosis, which I'll have to get you to look up because I don't know how to open videos here, that you'd use the Dix-Hallpike maneuver, where you're pretty much they're on the bed, they're up, you turn the head to the side and you pull the head back, and you're looking for this nystagmus of the eye. And something called an Epley maneuver can be used to treat as well. We are pretty much trying to get the crystal back in place. But also just being aware, it's a benign condition. Often if people left it long enough, then the body would kind of adapt and settle physiologically, so it would get better. But it's, although it's benign, it's really horrible for patients. I mean, they often are really nauseous and vomiting alongside it as well. So that hence why it can be better to treat it sooner. Going on to Meniere's disease. So Meniere's disease is a condition where you get a buildup of fluid inside, or of endolymphal fluid inside that vestibular system. They're not really sure why this happens or the causes. There's lots of ideas. But pretty much what happens is you get this buildup of fluid in your or endolymph in your vestibular system, and that causes these episodes of this vertigo because of that fullness and that pressure inside the system. And you also get this pressure, usually get some fullness or pressure in your ear because of that as well. And often it is associated with some low frequency sensory neural hearing loss, hence why your cranial nerve exam can be really important, and sometimes tinnitus as well. Often people have always had recurrence with this, so it's not just a one-off episode. They've had it a few times, and they often last less than a day, but they're longer than BPPV. They're going to be hours at a time. All right, and the treatment is very varied because they still don't really know the cause, but it's often things to try load that pressure off, like diuretics, a low salt diet, and steroids, and also giving things like antiemetics and suppressants to the vestibular system to kind of calm everything down, really. All right. Cool. So looking at now vestibular neuritis and labyrinthitis. So again, so far, these are all four peripheral causes of vertigo. And vestibular neuritis is inflammation of that nerve, of the vestibular nerve, and labyrinthitis can be of the actual inner ear or the nerve as well. So neuritis is and labyrinthitis is similar presenting wise. They're often this one-off episode. You can only get it once in each year apparently, that lasts for over 24 hours. There's like in Meniere's disease as well, there's something called a head impulse test, which I would encourage you to look up as well. And if that's positive, that indicates a peripheral cause of your problem. So that could, again, be a useful test to do to differentiate between the two. Again, looking at that nystagmus as you move the head. And the only difference between these two is that in labyrinthitis, you often get unilateral sensory neural hearing loss as well, whereas you don't get that with a vestibular neuritis. So that's kind of the only differentiating factor between the two. So that's why it's so important to ask about these associated symptoms. Okay. Going on to central causes. So plenty of central causes as well, such as strokes. And it can present with an ataxia, also vertigo, but there's usually no hearing loss associated. And again, as you would expect, it's this one-off episode lasting for a long time, over a day. Could be some associated, if it's cerebellar, it could be associated, cystokinesia and so on. So good to ask and test for that. But there's some key maneuvers again that I would encourage you to look up that I've mentioned there. So vertical skew deviation and gaze predict nystagmus, big names, but really simple tests if you do them. And again, if they're positive, they indicate a central cause. So again, important things to know about. Migraine related, so you can actually get vertigo associated with migraines as well. I know we already talked about these, but just good to know. Obviously they're going to be recurrent. People tend to get migraines more than once if this is the case, and they're likely to have some associated ache as well. But these can vary with duration and times of hearing loss too. Okay, so going on to a fever now. So I think obviously most commonly they're caused by infective causes. And so therefore you're often going to have some other symptoms that kind of give you a clue to what system might be infected or there might be a problem. But I think it's important as well when you're looking at a patient with fever or you've got an exam with someone with a fever to be thinking of things outside of an infection, because there's lots of other causes of a fever, and sometimes you can get a patient presenting with an unexplained cause or just a fever in isolation, and you need to be thinking about these extra things. So I've mentioned some of the important history points there. Screening for infection, of course, so all your organ systems, urinary symptoms, lung symptoms, travel history and sexual history is really important, but also looking for any devices, any surgical sites or anything that could be infected, and asking about joints, rashes, skin, eyes, things like that might indicate an autoimmune problem is really key as well. And a septic screen is what you're probably going to want to do in terms of investigations, which I've listed there. It's pretty much a screen through most of your body to identify any infection or cause of a sepsis or But I've just listed to the right here as well some other causes. So other than your obvious infective causes, you can also get autoimmune. They can present with a fever, things like a giant cell arteritis that we talked about before. But things like SLE and stuff, they can also present with a fever. So it's important to have that in your mind. Also, if they have a large infarction, it can present with a fever. Certain drugs can cause a fever, atelectasis, and importantly, lymphomas as well. But you'd hope that there would be maybe a neck lump or night sweats or some other things as well. But so just important to be aware that it's not just infections to think about. Just really quickly on sepsis, because I actually never got taught how to manage this last year, and I think obviously it's super important. So sepsis is a medical emergency where the infection is no longer just local and it's spread into your blood, and so it's multi-organ kind of failure because of this. There's this Q-SOFA score, which I've kind of briefly summarized there, but it's a way of scoring how severe it is and how likely sepsis is. So if you're scoring above 2 on this, you're thinking it's sepsis, or you're considering it at least. Obviously, if they're elderly, pregnant, or immunosuppressed, you're going to have a higher suspicion as well. And then there's also SOFA, which is not the quick one. So the Q-SOFA is the kind of abbreviated one. This image here, the diagram, that's just been taken from the Waitemata, how Waitemata do it. But good to have a kind of systematic approach for this. In your OSCE at the end of the year, that sepsis is a really easy, common thing to come up. So good to, obviously you're always starting with your ABCs to make sure the patient is stable. Identify the about that day there surgery or something, you want to be doing all this in this list that I've done here, considering your rapid IV access and your circulation part, getting those blood cultures, getting all that, any signs of infection, monitoring the urine and fluids and so on. I just thought that might be useful to have. Cool. And now I'm just going to quickly talk about anemia. So I think there's just 1 or 2 more presenting complaints, so not too much longer. So anemia, something that I got quizzed on so much and pretty much every run last year, so really good to just know this as well as you can. And I mean, it comes up in progress tests a lot too. But anemia, as I'm sure you guys know, is when your hemoglobin is low. So in females, it's below 120. And in males, it's below 140. And your risk factors, so if you're female, obviously, and you're menstruating, both extremities of age, if you're pregnant or lactating as well. So especially want to be monitoring for it in these groups. And it's important because it can cause significant morbidity if it's not treated, such as, heart failure or just significant distress to the person themselves. But it also can be a sign of a more serious underlying condition, which we'll briefly talk about soon. So I think a good way to look at anemia is, you can't just say, oh, they've got anemia. You need to think about what has caused that anemia, because there will be a cause. Okay. And so the key way to differentiate the different anemias and work out what the causes are is through the MCV. So you've got your microcytic below 80, normocytic 80 to 100, and macrocytic above 100. And your normocytic can be divided further. I know I always hated all these cells in different words, but reticulocytes are the kind of precursor to red blood cells. So if your body wants to produce more red blood cells, you're going to get an increase in your reticulocyte count. So if reticulocyte count is above 2%, and you've got a normocytic anemia, you're thinking that you're hyperproliferative. So your body's it is able and wanting to produce lots of red blood cells. And to me, this suggests that there's increased destruction of the red blood cells, or there's been an acute blood loss, a hemolysis, but it means that your body is able to produce them because you've got a high reticulocyte count. And on the contrary, if your reticulocyte count is low, so less than 2%, suggesting it's hypoproliferative, we're thinking, okay, so we're having a problem with production here that might be causing it. And just briefly as well, your macrocytic, so it can be classified into megaloblastic, which put simply means you've got a problem with your DNA production. And you see those things on microscopy that I've put there, like your hypersegmented neutrophils, larger mature red blood cells. I'm not much for that kind of stuff, but good to know. And usually things like B12 or folate deficiency are causing these deficiency of DNA production. So good to know if you've got a megaloblastic macrocytic anemia, you're thinking, okay, how is their folate B12 levels? And then you've got your non-megaloblastic, so your DNA synthesis is normal. And the most common of all is iron deficiency anemia. So you see this, it's a type of macrocytic anemia. And here there's lots of things that are really important. So the main thing you also want to rule out is there any gastric problems, so or gastric disease. So maybe they do have a history of poor dietary intake, or potentially being vegetarian and not eating as much protein as they should, or iron as they should, sorry. Or it could also be that they have celiac disease, Crohn's disease, ulcerative colitis, they've had some resection of the bowel or something that has meant that they can't actually digest iron or absorb it well. Importantly, always to do serum iron studies. So I've mentioned there that if it's iron deficient, you'd expect them to have a low serum iron, a low ferritin, but an elevated total iron binding capacity, which I'm sure you've learned about before. Really key, so in terms of investigation, so if you've got a young female that's eating fine, or maybe she's vegetarian and she's menstruating, obviously you're going to be a lot less concerned than if it's a male the same age, or if it's someone that's postmenopausal or maybe not having periods. So you kind of need to look at it in context, but there's certain investigations that you should always consider in those that there's no kind of cause. So chronic blood loss can cause an iron deficiency anemia. So you want to ask about things like, have they had black tar-like stools, so melena? Have you noticed any blood in your urine or in your vomit? But also be aware that sometimes it can be microcytic, so they're getting blood loss where they don't see it, such as in colon cancer. And so if you've kind of got someone and you've got no explanation, especially then you also want to be considering things like a colonoscopy to rule out if it is a colon cancer. So that's a really important investigation. I've mentioned some other tests here that are good to think about depending on the patient and the presenting complaint. But my main kind of take home with anemia that I would like to drill into you is just always thinking about what the cause is. So not just being like, cool, they've got anemia, let's give them iron, or let's try and give them a transfusion. We want to know what is causing that anemia, because it sometimes can be pathological. Okay. My final topic that I'm going to talk about today is altered mental state, which is obviously a really broad topic and covers a lot of things, but this is, so common. I'm going to talk about dementia and delirium particularly, because you will be so surprised how many cases of each of them you see, and how important they are. So, an altered mental state in itself is a combination of how conscious they are, but also cognition. So obviously you could just have an impairment of cognition, which could alter your mental state, but you could also actually be losing consciousness, and depending on whether you've got one or the other or both, helps you to work out what could be causing it too. I've just, from BMJ, I've listed some different descriptions there. I wouldn't worry too much. It's just to show you that there is this whole spectrum of kind of different mental states you can be in. So many differentials. What I really wanted to get across here is, if you think about, so I've starred all the ones that are red flags, so emergencies and you should be concerned about, and as you can see, pretty much everything is. Pretty sure I should have put one bioelectrolyte abnormalities too. So just being aware that if someone is showing that they've got reduced cognition and altered mental state in any way, it often is an emergency and it is a problem. So it's something you need to be identifying. And I mean, you'll notice when you get back on the wards that often consultants are getting you to do a lot of mockers and ACEs and tests like that for cognition, and that'll be your job. But you hopefully will be able to see why that is so important. I guess the only other thing I'd note is that in terms of a history, it can often be quite difficult, especially if you've got a quite demented patient that is really, is maybe quite forgetful, or their cognition's really declined. And that can make it quite hard to take histories. So for that reason, it's important that you get collateral where you can. You're looking at their past medical histories and you're thinking about these differentials and ruling them out the best you can. Okay, so dementia, so common and getting so much more common. I'm sure most of you know someone with dementia. So what it is, it's this progressive loss of neurons causing a progressive loss of your cognition and your function. So the key there is, as I've highlighted, is progression. So it's a progressive disease, and the symptoms that patients exhibit are often progressive as well. As you can see, it's super common. So by the age of 90, 38% have dementia. And I mean, with our aging population and just in general, this is increasing. So it's really, really important to have a good understanding about it. So the levels keep increasing as well, but it is more common in females. And just something that's interesting is that the biological changes, they often happen much before, how do I manage? Okay. The biological changes are happening well before any of the symptoms or signs occur, so often up to 10 to 20 years, which is good to be aware of, I suppose. And there's kind of 5 aspects to dementia that are important to be aware of. So there's obviously those pathological changes, which depends on what the dementia is causing that damage. There's cognitive change. So yes, most people think of memory as being the main one, but there's lots of other different domains, so such as your visuospatial skills and all those ones. So it's important to realize that it's not just memory that's infected, it's all your other kind of areas of cognition. There's functional changes. So these, well, obviously this will kind of happen progressively, but where you can start to lose your ability to do your activities of daily living, you're showering yourself, looking after yourself. You can get physical change. So, when you're not looking after yourself, you can start to lose weight, become more frail. You can start to fall over more easily. And things like delirium can happen, which is really important. Dementia is a massive risk factor for delirium. And the 5th one, which I can tell you from having lots of personal experience with dementia, is definitely, I think, the most upsetting for families. And it happens in about 90% of patients. They have at least one of these issues, and they're really you can actually treat some of them. So yes, some of them you can't help, but there's plenty of them that you can treat or at least manage as well. And I think it's important that you in particular acknowledge these as doctors, because this is often what's going to cause the family a lot of distress, or the most distress. So their behavior and psychological symptoms. So your behavioral ones are things like aggression, agitation, they're wandering around, things like that. Whereas your psychological is your things such as your depression, your anxiety, your apathy, and then maybe even delusions and hallucinations as well. So just really important to be aware that there's a lot of different kind of areas of dementia. Okay. So types of dementia. So it is important in some cases to know the differences between these. While there, I guess at this stage, there's limited treatment or cures to these dementias, there's still quite a bit you can do. So as I've mentioned there are some reversible sources, and it's important that we do appropriate investigations in case it is reversible. It's important for the family, for future planning for the person, and so we can make it more pleasant for the person. And in terms of their, for some of the dementias, if you can identify the correct cause, there's actually treatments that can help. So Alzheimer's, I'm sure you've all heard about, commonly talked about. You get these tangles and plaques, and there's lots of different types, but the most common is this typical type, and 80 to 90%, and that's the one you would have all heard of, where you're getting it in older people, and it starts with memory loss, and you get the slow decline following this. Really important to do cognitive exams. So I mentioned the ASA, and then laboratory assessment, at least a CT scan, to make sure there's no actually structural cause. And then things such as memory clinics and acetylcholinesterase inhibitors can be useful as well. So some more interesting causes. So vascular dementia is the second most common cause, and the mechanism behind this dementia is an interruption to blood supply. So it's usually an atherosclerotic plaque or a narrowing or a mini stroke of some sort is causing kind of ischemia to different parts of your brain. And so because of that, you can sometimes get this kind of stepwise deterioration where it's like the sudden drop and then it's okay, and sudden drop and it's okay. And that's because if it's multi-infarct. It's a lot less predictable to Alzheimer's disease, and that's because it depends on where the damage is happening or the location. And another one that's quite interesting, so Lewy body dementia, and this includes dementia that follows from Parkinson's disease as well. So they both, Lewy body dementia and Parkinson's disease, start very separately, but they actually often end up with the same kind of presentation. This kind of dementia fluctuates a lot, so the patient will typically have really good days and then quite bad days, and it's really a key feature is these visual hallucinations. And I always found this so bizarre, but apparently there's often animals that are in these hallucinations, and they're often quite malformed or upsetting hallucinations. So it is important, if someone's seeing something or hallucinating, you're asking about these hallucinations and what's in them, because it can actually give you some clues. Also REM sleep disorders, so as in Parkinson's disease and Lewy body dementia, it's super common. And so this is where you are in your sleep, you cannot suppress your body movement in your REM phase of sleep, and you can also get really frightening realistic dreams. And in Lewy body dementia, memory is often not an early symptom. So they're often more likely to present as kind of psychotic. So as in they're seeing these hallucinations, or they're getting quite aggressive, rather than the memory side of things, such as in Alzheimer's. And this one in particular is important to recognize, because there are some good medication benefits. It's also important not to confuse it with psychosis. So if you give them some of the antipsychotics, such as haloperidol, it can make it a lot worse. So it's important that you are doing a full screen and considering this in anyone that presents with some psychosis. So I've mentioned it there, but there's actually they've kind of identified some medications that can really help and improve quality of life and symptoms there. Cool. Just finally on dementia, so frontotemporal. So this is where you're getting some frontal temporal lobe damage, and so therefore it's often more behavioral personality changes that you're seeing with these patients. What's quite interesting is this happens at a younger age. So often these people have dependents, they have children, they have a partner, and therefore it can be I guess a lot more, it can have a larger impact on other people, wider people. Often these people will actually have had problems with their relationships or with their work before they're coming in. So because of those personality and processing changes, that can be happening before they're diagnosed with this. Yeah, so again, it's important because they've got these dependents, and it can impact their life so significantly. I think it's really important to get onto this early. And the CT head's your best investigation there. You can often see the changes. Okay. Just finally, I'm going to talk about delirium, something I knew nothing about until I got onto the wards. So delirium is super common. As I've mentioned there, in medical wards, 20 to 30% of patients have it, super under-recognized as well. And it's really common after surgery too. Super at risk if you're elderly, if you're a child, or if you have some kind of intellectual problem. But the main problems, as I was saying, it's really poorly recognized on wards. and it can reduce survival for people. So it's really important to recognize. And when you're having these episodes of delirium, it actually can produce damage to your brain. So you kind of, if you're getting multiple episodes, your cognition will suffer. And so if you're not getting onto it early and managing it, that can have quite big consequences for that patient. So again, it's key to know what the patient was like before they got into hospital. If you have to take collaterals, that might be helpful, but a useful way to kind of determine if they're actually different to normal. But the key features of delirium are inattention and consciousness. So I always got told by my consultant last year that if you're ever in doubt, inattention is a great thing, an easy thing to test bedside. So can you get them to count back from 20, or count back the months of the year from November, or something like that, where it actually requires them to focus and pay attention. And if they're unable to do that, that's suggesting they can't, they're then unable to place their attention on the task. There's two types. So your hyperactive, which is a lot easier to pick up, where they're quite restless, and it's probably what you think of when you think of delirium. You often get these hallucinations. They're super agitated and restless and really can't stop moving. But there's also this hypoactive form, where they instead just become quite lethargic and withdrawn, and very commonly it's misdiagnosed as depression, which obviously can be a significant issue on the ward if you're just assuming they have a depression, or they're really sad or down when they're actually delirious. So important to realize there's this hypoactive form as well. There's so many causes of delirium, so I've listed, there's so many there, but I think it's important to realize that if someone is delirious, there often is a cause, and therefore if you can treat that cause as well as kind of manage their delirium, you can help get rid of their delirium, obviously. And it's often happening to people that are already a little bit susceptible. So maybe they've already got an underlying sickness, they've already got a cognitive problem such as dementia, and therefore they might just get a little infection or an electrolyte abnormality or something on top of that tips them over the edge into this delirium. Something as simple as constipation, and someone with dementia can do this. Obviously, there's also drugs and alcohol can induce this as well, so it might be important to do tox screens. In terms of management, I haven't really mentioned much here, but it's really key to make sure you keep them in familiar surroundings. So if you're changing their bed, you're changing them, moving them around a lot, that's going to add to the problem and make it a lot worse for them. You want to keep things familiar and regular while you're trying to sort the cause out and manage their symptoms appropriately. Okay. Cool. Yeah. I guess there's not really much else to add there, just that dementia is a really important risk factor for delirium. So in these patients, and there's a lot of overlaps, you need to be super wary of it in these patients that already have a cognitive problem. Okay, cool. So that's me done. So sorry, it was a bit of a random combination of, of different topics, but in general medicine, obviously broad, and you say about that I have learned from various doctors, and that I found super useful. And I think, so I hope that was helpful. If you have any questions at all, please send me a message. And I'm really sorry about all the problems at the start. Technology is not my forte. So yeah, but thank you very much. Bye.